where are we thinking about haplotransplants right now, given the safety of post-transplant Cytoxan in so many patients? Do you think that there's still a reason to be concerned about haplos in myelofibrosis patients, or do you think those can be considered as well?
Thanks for your questions. Very great point. I think that this is something that should not prevent anymore the use of haploidentical donor for stem cell transplantation in myelofibrosis. Of course, this is a kind of transplant that still has potential greater risk than conventional ones. But one point very important is that our patients with myelofibrosis are quite old. It's not so common to find a relative that is younger and in good health conditions to be a donor, while they might have sons, for example. And so this is really an important source. According to the guidelines, you should first try to search a donor in the registries, but then the haploidentical might also come first if there is also an issue with time availability and also preferential choice from the patient. But actually, this is an increasing field of donor for stem cell transplantation.
Thank you.
Maybe I go next. Alessandro, thank you for this great talk. I think you mentioned intermediate one risk plus TP53 mutations, which was incline one to proceed to allo stem cell transplant, if I understood correctly. What about ASXL1 mutations or other HMR mutations? If these patients are still intermediate, would any of these be reason enough for you to go on to send this patient to a transplant unit?
Thanks, Steffen. A great question, these two. So this might be quite simple in principle for TP53 mutation, because we know that this is a really high-risk mutation. However, on the other hand, I have to say that we have no evidence that a patient with single-hit TP53 mutation necessarily proceed to multi-hit mutations. And as I have shown and derives from the literature, the behavior of these patients with single-hit TP53 mutation may be not so different from the other ones. So this is a question mark, is something that, of course, you do not like your patient to have. Same, I would say, for ASXL1 or other high-risk mutations. So here the decision is not straightforward. It depends on a number of variables that you have to put all together. Clearly, these are high-risk mutations in terms of progression, but the question is how long will the disease take to progress? So it's really a difficult decision. In clinical practice, if a patient is, let's say, around 60 or something like that, and has a high-risk mutation, this is something that might promote the decision to stem cell transplantation in order to not increase the risk with age, expecting, however, some additional years of survival. In younger patients, one might be more careful. A final point I'd like to make, and this is just because this morning I made clinical activity, and I have a very young woman with myelofibrosis, and she came for second opinion. She had, actually, I had already seen her for second opinion, and she was coming with an ASXL1 mutation that had been discovered in another center, and the patient had been classified as a high-risk patient. However, the variant allele frequency of this mutation was 41%. And my question was, is this an acquired, a somatic, or a wild type, or a germline mutation? And so we performed the test, and that was a germline mutation. So this is very important in broad use of NGS. Sometimes we keep the data as they are, but should be very careful in assessing the somatic nature of some mutation outside those that, of course, are well known as being somatic only.
I agree. Thanks.
Thank you.
So I'll just ask another question if I could, and that's, so in AML, for example, I know there's a lot of clinical trials about, for example, post-transplant venetoclax or maintenance type of therapies. And, Rux may be used if somebody has GvHD resistant to corticosteroids, but I wonder if there's appetite for using Rux either first line for GvHD prevention or even in a low dose maintenance way for patients, if there's enough thought that there would be biological activity to prevent relapse rather in patients post-transplant, and if you know of any trials that are going on that.
Difficult question. So why I would say that there's no doubt that Ruxo could be used if you have a steroid-resistant graft versus host disease, as in other patients after stem cell transplantation. I'm not sure that, and to the best of my knowledge, there is no hard data from the literature that this might be used as preventive of disease relapse after stem cell transplantation. We have no strong data, but if we go back to what we have learned over the years about the role of ruxolitinib in managing the disease and in controlling the disease, and I would say the lack of clear evidence of disease modification by ruxolitinib, I would be surprised why it should be really effective as preventing relapse. On the other hand, we can say that there are, not commonly, but there are forms of myelofibrosis that also are IDH1 or IDH2 mutated, for example. And these might, in case of relapse, might also, if this is part of the clone, might be have some advantages from these target agents.